Hello, everyone, and good morning. Welcome to University of Toronto Lab Medicine and Pathobiology Hematopathology Community of Interest meeting happening in November 2025. My name is Dr. Sadaf Memon. I'm the pathologist at Mackenzie Health, and I'll be moderating today's event. The title of today's talk is Not Just Reactive Lymph Nodes, Non-neoplastic Systematic Inflammatory Diseases. Our speaker is Dr. Michael Seidman. He's an assistant professor at the Department of Lab Medicine and pathobiology at University of Toronto at University Health Network. Although Dr. Sedman is trained in United States, faith and prevention brought him in Canada in 2013. He began in Vancouver and then moved to University Health Network in 2019. His practice is focused on cardiovascular, rheumatologic, and autopsy pathology. He also has subspecialty certification in molecular genetic pathology. He's the director of surgical pathology and director of autopsy at UHN and has several roles in the hospital clinical informatics. He teaches graduate students and residents in his areas of clinical interest, as well as in lab management and quality assurance and improvement. He's a member of several editorial boards and participates in diverse collaborative research activities. Today, he's here to speak to us about lymph node findings in some rheumatological diseases that mimic in hematopathology diagnosis. So this event is accredited group learning, Section 1 category, as defined by the Maintenance of Certification of Royal College and Physicians and Surgeons of Canada. So you can claim up to 2 hours. Welcome, Dr. Seidman. The floor is yours.
Thanks so much. I really appreciate the opportunity to be here and the overly kind introduction, since I probably wrote most of that as, drunk in lies. So the Sadaf covered pretty well what I've been invited to do. This started with my ongoing interest in IgG4 disease, and Rosemary decided that I probably had something interesting to say, and I'm here to prove her wrong. So we'll go from there. My obligatory disclosures, as required by the university and the hospital, is the I don't make enough money to have disclosures classic feature. There are no absolutes in this. Non-neoplastic medical disease has a tendency to follow rules even less well than cancers do. Take all of this with a grain of salt, but all of these, they're distinctive features of the disease. Sometimes they're, sometimes not. Some of them absolutely require it, but these are some of the things that I'll be talking about to varying degrees. Now, two important features I want to focus on. The first question is, which of the following, which I'll show up in a second, can cause discrete granulomas in lymph nodes? Some are more obvious than others. You guys better at least know the first few. For sure, TB sarcoid. Anything else? I think there's 1, 2, 3. I think there's 6 on here. Yep. Bartonella definitely can. Hodgkin's definitely can. Mets, believe it or not, lupus, RA, and MCD cannot. They are soft exclusion criteria. Yeah, the one most people forget, non-Hodgkin's lymphoma can do it too. It's not common, but there are several well-described non-Hodgkin's cases. I stress they are cases that can show up with granulomas. I stand by the body only knows so many ways to respond to injury. Those of you who are old enough to remember Robbins, it lumps it into 4 categories total. So, it's going to run out of ways to respond to cancer, and eventually some of them are going to cause granulomatous reaction. Obviously, Hodgkin's, TB, Bartonella, and sarcoid are the classic ones. Important to remember that Mets can do it too. So just because you get a small biopsy that has granulomas in it, please don't jump to conclusions. You are certainly welcome to do every infectious stain in the world. Just remember the infectious stain sensitivity on histology is almost abysmal, with the exception of a fungus. Some things are easier to catch than others, but a lot of these I end up relying heavily on ancillary testing. So, some of the ones I specifically want to speak of. SLE is not described to have any granulomas associated with it ever. In my mind, so the 2 cases I've ever seen that came to me with SLE where I found a granuloma turned out to not be SLE. They had a lot of SLE features, but they ended up being primarily explainable by something else. One, the granuloma was outside a node and was actually GPA, and I forget what the other case turned out to be. Rheumatoid, it's important to remember, we always say rheumatoid nodules can show up anywhere. They are undescribed in lymph nodes. I actually went digging and could not find a single case report, which blew my mind because in soft tissue, the nodules can show up everywhere. Kawasaki is another pitfall because the granulomas show up in vessels, particularly coronary arteries, but also undescribed in nodes. Kikuchi, Kimura, and histiocytoses can have lots of macrophages. Histiocytoses in particular should be sheet-like. They should not be well-defined granulomas. I was shocked to learn relatively recently that granulomas are an exclusion criteria for IMCD. They're a soft exclusion criteria, so I don't think they appear in the formal diagnostic criteria, but basically people are saying if you find them, you're wrong. And it is an explicit major exclusion criteria for IgG4 related disease. Okay, now just to mess with you, which of the following can show monoclonal bands? And I'm referring to lymphocyte monoclonal. 6 of them are absolutely correct. As mentioned, my background's in molecular, so I had to deal with this. Castleman's is idiopathic multicentric is undescribed to cause monoclonal peaks. Yeah, I sure hope the lymphomas cause them. SOARE, those are all correct. There are LNH. I'm not sure what LNH is. I'm sorry. I'm trying to line it up to what I have.
It's probably non-Hodgkin lymphoma.
Oh, got it. I just put it together. Yeah.
Primary language.
There's 2 other big ones on here. So all the monoclonal means is you have clonal restriction of leukocytes. So Rosemary got lots of them. Yep.
Lymphomas more trickling.
COVID, believe it or not, is described to usually be monoclonal or oligoclonal, which isn't entirely surprising for a virus, and yet flu's not described to traditionally be that, which probably just means we're not looking. But and then one of them that you wouldn't expect is described to have monoclonal peaks. So believe it or not, Bartonella is described to have monoclonal peaks. Lymph node mets are tricky because obviously you could get clones that arise in response to them. I don't know what the most up-to-date state of the literature is, but I usually expect those to be oligoclonal, not monoclonal. Histiocytoses, I didn't outright cross out because most of them are probably neoplasms and do have other mutations that would suggest they are clonal, but they don't have the monoclonality in lymphocytes. And IgG4-related disease, I'm convinced we haven't looked enough. My hunch says that there are clonal restriction versions that are not neoplastic or not neoplastic yet. But the current literature says it doesn't happen. That said, I actually did sequence one case and got an oligoclonal result, so make of that what you will. To be fair, I sequenced it by accident. Someone insisted it was a lymphoma. Okay, and then the last ridiculous feature I'm going to cover, which of the following have a specific association with tissue eosinophils? Yeah, Hodgkin's the one that you guys all encounter, so I'm glad you caught that. Yes, I know it's specific version. No joke, it is undescribed to associate EOs specifically with any given non-Hodgkin's lymphoma. They're effectively incidental. I was surprised to learn that. Which histiocytoses? Because I actually got tricky on that one. Yeah, it's only LCH, believe it or not. Sure, I never get phone calls, and today I get a phone call. Really? I didn't know that, Sarah. Do you want to unmute and tell me some more about that? Because I was unable to catch that in my review. Sorry, that'll stop soon. We'll stop now.
Yes, some cases of T-cell lymphomas are described to have eosinophils, like angioimmunoblastic T-cell lymphoma also can have that. Yeah, so yeah, if we find eosinophils, we put T-cell lymphomas in our differential as well as Hodgkin.
Cool, good to know. I always like when I learn something. There's one other on here. Okay, angioimmunoblastic, I'll have to remember that. The whopping one case I saw in training did not have ES. There's one other on here that, believe it or not, will probably be classified as a hypereosinophilic syndrome real soon. Yep. IgG4-related disease has tissue eosinophils in roughly a third of cases, depending on the circumstances. They're often subtle, but I've had several cases where the EOs were predominant. Officially speaking, peripheral hypereosinophilia is an exclusion criteria right now. That says I found multiple cases clinically since working here where it was still probably the right diagnosis. So I think the major reason it's listed as an exclusion criterion is just based on the validation, which we'll come to later. It's important to remember that the current best criteria for IgG4-related disease are specifically described as a working criteria. So it'll be interesting to see how those evolve. Okay. Going to start with the real easy patterns. So these are the rheumatologic diseases that can cause lymphadenopathy and tend to have absolutely no specific findings whatsoever in the lymph nodes. So ironically, these are the ones that are just reactive looking. The major takeaway being just because the nodes don't show lymphoma doesn't mean the patient doesn't have life-altering disease. And just because there's no specific pattern doesn't mean they don't have life-altering disease. I fully recognize that in the setting of an insanely busy practice, it is hard to do so, but ideally open the chart and just look for a second. I've had multiple cases that came to me, rule out lymphoma. All I got was, all that the hematopathologist got was a core of a reactive lymph node. And after sign out, a rheumatologist reached out to me and it's like, well, why didn't they consider SLE? I'm like, because you sent them a reactive lymph node. Well, it turns out the patient had a screaming positive ANA. So, you know, in theory, we're doctors. We always say we're fake doctors, but yeah, we're real doctors. Some of you probably even still see patients. But the reality is we are responsible for looking at that. I would argue I can train people to look at a slide and describe it anytime. I do encourage you to remember that our job is to provide meaningful patient care. I think we are qualified to provide explicit diagnoses, not just say things are consistent with. There's nothing wrong with saying things are consistent with. But, you know, when we know more, I think we can do a lot for patient care. Just recently, I caught that they had completely missed a diagnosis of poems in someone. Like they had literally every descriptive feature and it had not occurred to one. The doctor of doctors I love. I don't think I've ever heard that. Love. Oh, I'm probably too young to have heard that, which is funny because I feel old today. I'm hoping most people have seen sarcoid before. Granulomas and sarcoid really should, especially in lymph nodes, be very discrete, very well formed. You can draw a line around them kind of thing. You do frequently see them with a lot of fibrosis if they're longer standing. So this is a nice cellular example, but I've had cases that were predominantly just punched out scars and you had to go hunting. I will say that everything still says this is a diagnosis of exclusion. I'm not going to outright call BS on that, but there's a look. Like if I get a lymph node that looks like this and they've already clinically excluded that this looks like fever and it's been going for a year and they responded weekly to steroids, I'm not going to do all the stains. It's not compelling, especially because it would be more likely to be AFB than anything else at that point. And as we all know, the sensitivity of AFB stains isn't great. I don't know that PCR is any better on nodes, so I frequently encourage them to do a clinical workup. When pushed back, I will do the stains if asked. Rosemary's had the only case that was an unexpected positive that I've ever encountered. And then hers also was post-treatment and didn't behave the way I would expect the stains to. So the moral of this story is I am frequently wrong. Kimura, some people have seen, some haven't. Considerably less frequent in North America. This is probably better known by the various eosinophilic titles. It can involve extranodal sites, but it's very classically a nodal disease. It is benign and indolent, but can recur. So this one is not self-limited. It will keep going. The patient might have to deal with this for life. And I honestly don't think the treatment guidelines are very robust. So, you know, you get to have a conversation if you're involved in that. It is important. I didn't show a good picture of it, but it is important to find hyperplastic follicles. And it's the interfollicular areas will look like this. It's funny, most of the good examples of this are so overly red that you couldn't convince yourself you were looking at eosinophils. I was really surprised. And then I couldn't find any examples in the last 2 years here at UHN. You'll frequently hear people describe the eosinophilic microabscesses. In other words, a bunch of the eosinophils are touching each other, and outright necrosis may be present. This one is really, you know, when you see a node that's too eosinophilic, you have to go looking for the right story. I've never actually seen a live case. I've only ever seen teaching cases. I don't know if anyone's encountered one. this tends to be in Asian individuals at higher frequency, but I also kind of wonder if there's an ascertainment bias because I just don't know that we would think of it all the time. One with a very similar breakdown is Kikuchi disease. This one I've actually seen two of, but I could not get the slides out fast enough to get good pictures of, I realized, because that was my fail. So this is the necrotizing lymphadenitis, almost always benign and self-limited. I have seen people get complications like superinfection, particularly with treatment. The most amazing thing to me on this disease, and I like challenged it when I first encountered it, the Karyorrhexis is not caused by neutrophils, unlike everything else. And one of the ways I eventually convinced myself that might actually be true is you'll also notice there's no neutrophil extracellular traps. There's no netosis. It's, you know, you would expect when neutrophils blow up that their DNA would extrude and you'd have the blue gunk. There's no blue gunk in this disease. So those are actually macrophages and plasmacytoid dendritic cells blowing up as far as we can tell, and can have overt central necrosis. It's not a required feature, but if you have overt central necrosis and no neutrophils, this is a really good thing to consider. I had forgotten about this until I was preparing for this talk, but there are three classic phases described in the literature. The proliferative, which is you have a whole bunch of macrophages proliferating. It's really not that interesting. Necrotizing, where the overt necrosis shows up. And the fascinating one is the xanthomatous, which is probably just a histologic variant of the same thing. Even in this image, you can tell that some of the cells are foamier than others. Interesting side note, I was was at my first sign out actually in training, and I was asked by the staff, I had a case with a whole bunch of foamy macrophages, and he asked what I would call it, and I said I would call it a foamoma, but he was looking for xanthoma. So I stand by we should rename it. We can spend a little bit of time on the primary histiocytoses. The bottom line is I was having a really hard time finding pictures to make the conversation worthwhile. So I didn't go too far into this. But I do think it's important, especially if you haven't encountered these, to go through the 2016 classification. These were revalidated in, I think it was 2024, and then there's a New England Journal paper about that revalidation. So this is, to the best of my knowledge, the current classification. The L group emphasizes what just changed. Did someone raise a hand? No. The L group really emphasizes that LCH and Erdheim-Chester are molecularly tremendous overlap. I've actually done a couple cases where I highly suspected these, did kinase-specific sequencing. I think we did like 15 or 16 genes, and several of them got hit in non-BRAF. I certainly do the IHC first, but I haven't had a V600E positive case in a really long time. So, you know, these do seem to have striking molecular overlap, some clinical similarities, but no overlapping histology. My personal favorite is that there is, in fact, an indeterminate cell category. Indeterminate and mixed are often used interchangeably. In my mind, if you can find an area that meets one and another area that meets the other, that's when I use mixed. I've never encountered a case. I've definitely caught cases with like no eosinophils and a subset CD1A positive. For Erdheim-Chester, I actually find the most helpful stain to be factor 13A, where all of the histiocytoses have some factor 13A staining. Erdheim-Chester should have diffuse whopping positive factor 13A staining. So in the absence of CD1A Langerin, S100 is kind of variable and patchy in Erdheim-Chester. I find factor 13A very helpful. I have not found alpha-1 antitrypsin and lysozyme particularly helpful, other than, yeah, they're macrophages. The cutaneous group is the one I more often end up just calling C group because nothing ever falls into a nice category unless you're on the derm service. But juvenile xanthogranuloma has God knows how many relatives now. I stand by they're largely semantic differences. There's not great molecular characterization to date. But there are systemic variants. So the systemic xanthogranuloma tends to be soft tissue. I couldn't find a compelling case of it involving nodes. That said, progressive nodular histiocytosis and multifocal reticular histiocytosis, in both cases, I have seen lymphadenopathy, where then there were deep soft tissue lesions. So one person with PNH kept getting them in their joints. but with no skin involvement, had lymphadenopathy. We never got one of the lymph nodes out, so I don't know if it was strictly speaking histiocytic in the lymph node. But I do think it's important to remember that a lot of these diseases break the classic rules and can be multiple. And I mean, the same thing with a lot of solid tumors that will end up mimicking lymphomas, et cetera. So I just think that's important to keep in mind. This group, I don't need to lecture much about Rosai-Dorfman. You guys probably see a lot of it. Obviously, in the absence of CD1A, S100 is the most helpful. I do reserve this diagnosis even with compelling histology for when it's diffusely S100 positive. I have at least once called something R group NOS. And the paper and subsequent literature does speak to that being completely reasonable, that you can just diagnose the group and you're still providing useful information. The malignant histiocytoses is one that always challenges me because there's not a whole lot of compelling primary ones that we think of as primary histiocytoses. So, you know, the ones that were always told to me when I was younger was histiocytic, in air quotes, sarcoma, it wasn't the dendritic cell one. There was another one that was always told to me as, myeloid sarcoma. Were told to me be those, first off, neither of them sarcoma. The soft tissue groups want nothing to do with them and wish that word would go away. Chris Fletcher used to enjoy looking at them just so he could prove he was smart. We already knew he was smart. I have seen one malignancy grow out of a histiocytosis before, and it was a lymphoma. So make of that what you will. Interestingly, I have also seen a histiocytic sarcoma grow out of follicular lymphoma, which is also reasonably well described. So the M group, I'm sort of not sure if it's anything other than a dumping ground for the things that don't fit nicely. I would argue when you have a malignant version of any of these, your patient's in trouble. Just so you know, one of the worst prognostic factors you can have for a patient is your pathologist gets excited about the case. Age group, I am going to get on a high horse for just a minute. I find the term HLH has become massively overutilized, particularly in the ICU. I would argue finding that you meet the clinical criteria for HLH is roughly the same as saying you meet the clinical criteria for sepsis. The primary monogenic forms almost always show up in childhood. That is a distinct disease. There's no question. There's a great literature on that. We even know most of the genes now. So I think it's 90% of cases they said they could account for the gene now on the most recent study. The secondary is where I finally really go down the tubes. Sepsis, MASC, MIS-C, et cetera, cancers, most infections, particularly viral, EBV is very common. Most rheumatologic diseases can all trigger this as a secondary event. So diagnosing it's not necessarily helpful. It is effectively a finding a cytokine storm. And in fact, the specific one, macrophage activating syndrome, is where it overlaps with the rheumatologic disease. And historically was on a spectrum with adult onset Still's disease. So you ended up with this really complicated situation where depending on where your rash was and if you had HLH or not, you got a different terminology. The major reason for lumping those was the overlapping clinical features and the absurdly high ferritins. So HLH, almost regardless of the cause, is characterized by a 5-digit to 6-digit ferritin. So their acute phase reactants other than that tend not to be proportional. And that can be one of the things hinting at these. Idiopathic HLH, I think, is worth identifying. My two compelling cases of it, one had a very weak story for their first case of mono 6 months earlier, and another one met, I think it was 5 out of the 7 required criteria to diagnose lupus at the time. I actually don't know how many criteria are required right now, but was very clearly, you know, they had an EBV related and a lupus related, but they didn't meet classic definitions. So in that context, I found it relevant because it sort of hinted at the, no, they have something else. Both those cases were at autopsy. So I just don't think they had the opportunity for the disease to fully manifest. I will say most of the cases I've encountered in the ICU were patients with sepsis, which I didn't find it particularly compelling to pull out that they had HLH from the what actually killed them, which was everything other than that. I don't know if anyone had any other thoughts on histiocytoses, any questions, any discussion points. I feel like this is one of those things that bleeds into hematopathology every so often, bleeds into rheumatology, and I feel like it's more every pathologist is expected to notice this particular set of zebras on a whim. I'm always learning more about these, and I'm just wondering, what's the hematopathologist's point of view on this? Come on, someone's got to be not shy besides Rosemary and Sarah. Let's start with, has anybody seen a good case recently?
I saw a potential Erdheim-Chester disease case based on the radiology. The radiology apparently was suggestive, according to the radiologist, where there was peritoneal nodularities, and they thought it was pointing towards a histiocytosis. And there were histiocytes that were foamy and kind of looked morphologically like it could be an Erdheim-Chester type morphology. I actually did not order a factor 13. I did do a BRAF immunohistochemical stain, and that unfortunately came back negative.
Negative.
The patient did have a high hemoglobin that had been long-standing, and so the clinicians decided to continue the search with a bone marrow biopsy to both figure out why hemoglobin was high, and then to see if maybe they could incidentally pick up the histiocytes in the marrow. And this was very recent, so I haven't seen the marrow, but in general, I struggle with the histiocytoses. They are very rare. I have seen Langerhensel histiocytosis. I had a case that NIH called Erdheim-Chester in the bone, but then later when we correlated it with the radiology, it did not fit. Didn't have the long bone lesions.
Yeah.
Yeah, I don't know about that case. Rosi Dorfman, we had a really interesting case that was was forming a retroperitoneal sclerotic mass, but also was involving the eye, lacrimal glands.
I've never encountered that one.
Yeah, and it was like a weird form of Rosi Dorfman. So apparently there's a subset that are more neoplastic, and you don't get the typical appearance with the emperopoiesis, and it really looked more like a IgG4. Like there was lots of plasma cells, but also lots of histiocytes, and very fibrotic, and we got a MAPK mutation in it. So
oh wow,
yeah, so
that's pretty cool.
That was a neat case. Yeah.
So did you actually do the factor 13? I'm curious. Like, was it possible it's a funny Erdheim-Chester?
I actually wrote it down now. I'm gonna go back and do the factor 13. Previously, like I just haven't ever used it, so didn't know.
I got lucky a few years ago and it was helpful. But no, the reason I ask is I think there is an overlap between Erdheim-Chester and Rosi Dorfman phenotypically that we've been missing. Sort of most people learn about Rosi Dorfman in training. I find fewer learn about Erdheim-Chester, which is fascinating because I've seen probably a dozen cases of Erdheim-Chester and one of Rosi Dorfman. Now, granted, I'm in the cardiovascular space, and the mediastinum Erdheim-Chester is way more common. So I've seen periaortic, I've seen pericardial, all sorts of crazy stuff. But those are some really cool cases. These are hard. There's no question they're hard. And they sort of rest right between neoplastic and reactive in terms of the way we can work them up. I think they're going to evolve more and more. And certainly as we do more and more sequencing, I think a lot of these are going to start showing recurrent clonality events. But, a MAP kinase mutation always makes me think it's actually L group. And I think it's more likely that there's funny histology in L group we haven't defined yet than that Rosi Dorfman would have overlapping features, so to speak. Obviously, we know the familial Rosi Dorfmans probably have something. It does amaze me that we've not reliably found anything in the sporadic cases yet. But yeah, it's a really cool space. I have to admit, most of my C groups, I only can ever diagnose C group. They never look quite right. But one of the cases you described a really cool fibrosis and cleared out macrophages, and I think we'll have a chance to come back to that. Does anyone else have really cool cases? I'm happy to go forward. We can come back.
There are no questions here, Michael. I think we're good to go with our presentation.
Okay. Very recently, you had a much better talk than I can give on idiopathic multicentric Castleman's. I have taken to synoptic formats for both my IgG4s and my IMCDs, and especially when they're overlap cases, I will put both synoptics to emphasize why I think it's one versus the other, or why I can't tell. Obviously, this particular publication, I didn't put the reference for this publication. I'm so sorry, although a lot of you have seen this before. There's some new clinical entities, but as far as I'm concerned, the histologic scoring, particularly in the nodes, really is still best done via the 0 to 3 system. I am not convinced that we have any meaningful prognostic or treatment ramifications from that yet, but I think we have to collect the data so that we can eventually do that. So now I'll go into IgG4. I used to say that the most common cause of elevated IgG4 is everything except IgG4-related disease. That's probably still true. A tremendous amount of my consults are the convincing people that it's not IgG4. And then every so often I get a really great IgG4 case. Obviously, people know this is a spectrum, can involve all sorts of organs. I've taken to it can involve almost anything. We'll get to the canonical organs in a second. For all intents and purposes, it's a histopathologic diagnosis right now in the absence of clinical exclusion criteria. Important to remember that serum IgG4 elevation is not a required feature, and in fact is a de-emphasized criterion in the new features. I will also say that the end stage of most chronic inflammatory diseases looks like IgG4-related disease. So the first place I encountered IgG4 personally was in aortitis. The most common cause of IgG4-related peri-aortitis pattern is actually burnt out giant cell aortitis. So there's a whole set of publications on the don't get fooled, make sure you rule out everything else first. Some of the things people do forget is they almost always has a significant background of M2 macrophages. If it's had time to develop, the fresh cases haven't had time to recruit it. Often has eosinophils. I'm going to do my speech on what storiform fibrosis actually means. You know, some people say it's whorling. I think the literal word means woven. I just want it to be sort of no pattern. So I don't want it looking like scar. I don't want it linear. I don't want it, perfectly corresponding to where a granuloma might be, but sort of any non-specific fibrosis, I tend to put into this category, mostly because the definition is so vague that it gives me the opportunity to upgrade my findings. I will say I can look at a case and sort of get a sense of it looks like what I've seen before and it doesn't, but that's just because I see these cases in consult. I suspect most of you will identify the same pattern because it doesn't look like the other fibroses. A lot of people still put a lot of weight on the phlebitis and arteritis. I find it very hard to find, especially in biopsies. So I tend not to rely heavily on that. When I see it, great, but as you'll see, it's also, if you have the fibrosis, they're relevant. And it is important to remember that IgG4 can evolve into lymphoma, particularly salivary gland. I've seen 2 really compelling cases where it was just too infiltrative, got the kappa lambda, and in both cases, it happened to be 100% kappa. There was not a lambda to be identified. So that patient actually started getting treated as though it was lymphoma, because there was really nothing else we could do to distinguish them. And sort of the masses were growing very rapidly, et cetera. So they did go down that road and treat it as a MALT-type lymphoma. So here's just an example of the M2 macrophages. So admittedly, this is not the most compelling field for the IgG4 staining. The IgG in this case was a mess. I had to use the 138. So if anything, I'm overestimating the denominator. That said, in various spots of this complex core, it was up to 70 IgG4 positive cells per high power field, and in those areas up to 46%. So it just barely made the classic criteria, and we can discuss the new criteria in a second. But the important thing is that it had a ton of M2 macrophages filtered in between. The important thing for me, and I've seen much more striking than this before, is don't go down the road of thinking it's a histiocytosis. Histiocytoses should be back-to-back macrophages when they're distributed like this. And in fact, the original paper on this, it was every other cell, but it was every other cell. They weren't back-to-back. There was almost a checkerboard kind of thing with the plasma cells and lymphocytes. So this is more just don't go down the tubes on that. I think people have probably seen eosinophilia described in this. This is a reasonable example. I think this was one of the kidney cases we had, but I've seen it in almost every organ. Frequently, they're hard to take a picture of, but they look really compelling on your slide. I should probably do a GIMSA one day just to take a cool picture. But peripheral eosinophilia remains a formal exclusion criteria, but like I said, I've seen it. I actually think there is an IgG4-associated hypereosinophilic syndrome, so I think it's important to consider. I guess that would most be relevant when you guys are working up the neoplastic HESs, just to consider the possibility that they overlap. So this is the original 2012 criteria, which have then been perpetuated by both the Japanese consensus criteria. I think their most recent is 2020. I found this extremely limiting. The major reasons why: one, it's an absurdly high bar for certain organs, which is fine for specificity but useless for sensitivity, and therefore was actually blocking treatment of certain patients. This was most relevant back when rituximab was special access only, and by special access only, I'm an American, I should say. That meant it wasn't paid for. It was after approval, but when it cost $10,000 an injection. I don't think it's anywhere close to that anymore. And last I checked, it's pretty readily available, even in Ontario. I found a lot of the organs where I've encountered this completely missing. So breast pseudotumor I've seen 3 times, which I didn't know which one to compare this to. Aorta, I've actually seen multiple cases that were below this, but had no other explanation. I also, for the life of me, cannot tell you what the difference between histologically highly suggestive and probable histologic features of actually means. In my mind, those both say maybe. So I haven't gone to great lengths discussing with Vic why he chose these terminologies, but in my mind, it's either yes, maybe, or no. And this I found a little unsatisfying in that regard. I will also say if all I have is the one feature of dense lymphoplasmacytic infiltrate, I tend not to go down this road too aggressively unless my IgG4 staining is really obvious, the clinical story really obvious, etc. So then 2019, which was actually published January 2020, just to make things confusing, ACR and EUAR published an updated set of criteria. There was a pathologist involved who I know, who's very reliable, very diligent, and they really, past that, they also looked at the literature really well. This is one of the better meta-analyses of a disease spectrum like this I've ever seen. One of the interesting things about it is they did explicitly define the entry criteria for making the diagnosis. And you'll notice one of the funny things is lymph nodes isn't listed here. So despite the fact that it's well described that IgG4-related disease can cause a lymphadenopathy, in the context of isolated IgG4-related lymphadenopathy, you can't actually make the diagnosis by current criteria. I think many of you know that. Probably many of you at some point or another have said possibly consistent with or elevated fraction. The one time one actually got bumped to me from a lymph node, I went digging through the chart and they actually had hypothyroid for eons. So turns out eventually that person had Rydell. So there's then a long list of exclusion criteria. Some of these I use aggressively, some not. So like I talked about the peripheral eosinophilia, for example. I've seen cases that were refractory to glucocorticoids, but were nonetheless IgG4. That's actually well described as well. I have always excluded it when I have a disease-positive antibody. The radiologic ones are tricky for me because it requires that you actually believe your radiologist, as was mentioned by Alexandra earlier. It's, I always have to take radiology with a grain of salt. For some reason, when they make a mistake, it's okay, but if we make a mistake, it's the end of the world and we should go to court. I have yet to figure out why that is appropriate or fair, especially because we're the ones that bother to accredit and they're not. Obviously, malignant, other tumors that you can't exclude, et cetera. The macrophage histiocytic disorder is one where I specifically have gotten cases that this must be an histiocytosis. I did do the 163. They weren't sheet-like, like I showed before. It's always interesting. So the second and third of these is real easy because you can believe that they probably have an accurate diagnosis most of the time. But I find it interesting that if you have a confirmed diagnosis of a disease, that's a soft diagnosis most of the time. So MCD and IgG4 frequently overlap, and we do the best we can do. So you then get to the point system, which is why I really love this, is you start with the histopathology, and in general, I can usually get to 13 points on a case where I actually think it's IgG4. There's then some IHC criteria. You'll notice that these criteria include scoring for things way lower than the 2012 criteria. And I'll loop back to that in a second. But the paper really goes into a nice algorithm for this. And I built a synoptic based on this for what it's worth. There's then a whole list of clinical exclusion criteria. Inclusion criteria. So points for various clinical features. More often than not, all I ever find is the serum, but I've had a couple cases that I bumped over because they had findings in other characteristic organs that had been dismissed. So ultimately, the goal is to get to greater than or equal to 20 points with no exclusion criteria. If there's no exclusion criteria, you have the lymphoplasmacytic infiltrate, you have fibrosis, and you have even a few IgG4 positive cells with high fraction, or a tremendous number of IgG4 positive cells regardless of fraction, you're already at 20 points. So it actually makes it much easier for us to say, yeah, maybe. Which photo was a wow? I had a good photo? Where? Anyway. Oh, that was probably back on the eosinophils and histiocytes, sorry. So just keep this in mind, that it's really important that we actually not blow off IgG4. It's not just a fraction, and that it's very reasonable to use these criteria, especially because our clinicians are using these criteria now. So we start to look kind of dumb if we haven't caught up. It's interesting, these were published right before the revised 2020 Japanese criteria. I've received consults where they're like, slam dunk, no, there's no way this is IG4, blah, 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 blah. And at least one of them got to 34 points. So, and had no exclusion criteria. So, I think there's a lot going here. These are admittedly provisional, working criteria. If you actually dig into the criteria website, they are certainly going to be revisited at some point. It's funny, there's actually a commentary that came out with this from two people in the U of T affiliated system who basically said, wow, this is really complicated. This is great research, but will it matter clinically? Ironically, I work with one of them all the time and we use the point system. So it proved to actually be very useful. And a lot of the patients that meet criteria do respond to rituximab, which is really important. I then have a couple entirely contrived cases, but Sadaf, I don't know what you want to do next. If you want me to come back to these, you want to have questions first, etc.
Sure. What we could do is, if at this time, if anyone has any questions, please feel free to ask. You can unmute your mic to ask the question, or if you feel shy, you can even post it in the chat box, whatever way you all are comfortable with, and then we can do the case examples, Michael.
Oh, I have a question. I work in North Shore General Hospital. This is a large community hospital, but I got several times cases from our AP colleague, just a very small, tiny biopsy, and because they saw some storiform fibrosis, which I cannot tell, and asked me to rule out IgG4 related disease. So, what approach would you take regarding this kind of request?
Yeah, so if there's enough material, I stain it. So if there's enough material, almost as a rule, my IgG4 workups, I've been getting 320, 138 IgG and IgG4, sometimes get a 68 and 163, sort of depending on my gut feeling, the histology, etc. When it's really scant, I have been known on at least one occasion to get nothing but the IgG4, because if it was whopping positive, it's obviously informative. I stand by any pathologist in this day and age should be able to order an IgG and IgG4, even if it's a send out, and do math. So, I'm not sure bumping it's necessarily the right solution. Certainly, I would encourage people that if you get it, have fun with it. I happen to think it's a very cool disease spectrum. I'm happy to take them when you truly run out of options. We certainly see cases from you folks frequently. But yeah, the one case, two cases I didn't work up. One was I couldn't histologically find a plasma cell. Like there was nothing that even suggested a plasma cell. And I'm like, well, if I only get to one, that's not helpful. So there's no reason to work this up. I specifically said, I can't say it's not, but not a good biopsy. And then I've had at least one biopsy that was so scant that I knew I was going to level through it. The specific situation was they had done a gorgeous lymphoma workup, concluded it wasn't lymphoma, and there was nothing left in the block. But I tend to try. The justifying rituximab still does require a pretty solid diagnosis. I have not encountered many situations where they can give it empirically. And since it is a life-altering treatment for these patients, I do try pretty hard.
Oh,
And we can always ask for repeat biopsies as well if this tissue is not sufficient.
Yeah, I mean, sorry, I should say I take that for granted that as pathologists we mentioned that. I also stand by our clinicians should know that better than they seem to. I don't know that I'd wish a bone marrow biopsy repeat on a person if I can avoid it, but yeah, nodes, I'm like, just take the node out. So I hope that answered your question,
You don't
Stephen.
have 163. What are the options? Do you think C68 is good?
68, the KPG1, KPM1, whatever it is, isn't bad. Sorry, PGM1. The PGM1 isn't bad for this. I have noticed that the KP1, which is the so-called more specific, is a very M1 biased stain. So if all you have is the KP1 clone, it's tricky. But if you have PGM1, I find that it stains about half as much as the CD163. I will also say that unless I'm trying to prove it's not astheocytosis, I don't find it essential. So I usually only look at those when someone's like, oh, this is totally airtime Chester. And I'm like, except for the fact that there's no sheet.
Thank you.
You're also welcome to send it down here. I mean, we do any number of things technical only. You don't have to send a full consult. Send some unstained slides. We'll get it back to you.
Yeah, I just sent I think several cases, and the one is Rosette Hoffman. Still waiting for the results.
Yeah, our IHC turnaround time has some opportunities.
I think, Michael, we can jump right into your case examples, and then people have questions after that.
So this case I stole from sort of mini review type thing that I did when with a hematologist and a rheumatologist when I was in Vancouver. I've completely made up the clinical scenario because these are actually from two different patients. But a 53-year-old male has weight loss, lymphadenopathy, and pancytopenia. They take out a mesenteric node and do a bone marrow biopsy just because they hate this patient and find these findings. What are people's thoughts? Yes, it's low magnification. So play along. What stains would you want? I guess you guys order a panel of 20 sort of at a minimum. Yeah, so that was one of the first things I thought when I actually saw this case. The lymph node is my case. The bone marrow is not. It actually turns out that is legitimately a germinal center with just very bizarre morphology. But there were very few macrophages in that for what it's worth. The follicles were also running into each other, as you can sort of see at the edge. And there was, in one half of the node, there was no interfollicular zone. In the other half, it was lots. Hello from Nicaragua. Well, thank you, Carlos. But it's a really good comment. I do think the mantle zone is wicked expanded in there. I didn't go to the trouble of specifically proving it was still a mantle zone. But Carlos, you raise a really interesting point. How many diagnoses are now based on, like, defined by IHC and molecular, and it's tough. I would say that in a situation where it can alter treatment, find someone to send it to. I know a lot of us do international consults. A lot of places in the States will do them for free. And I do encourage considering that. I would say that if anyone on the photo is doing any reports not in English, please send a legitimate translation, not Google Translate, because I think too many people rely on that of your report and findings, excuse me. But I think it's worth going down that road. That said, my experience is a lot of places that don't have access to IHC also don't have access to the specific treatments. So, if all you have is steroids, I'm not sure it matters. If you can get access to rituximab by doing the work, I think it's reasonable to reach out to colleagues.
Do you have a higher power image of this, Michael?
I didn't, but I'm having fun screwing with people. So this is the IgG4 staining. I think this was a pretty clear-cut example of markedly increased interfollicular IgG4, which there are a few different patterns described. I'm not convinced that it matters, just not enough data. The interesting thing was it was little expanded in the bone marrow, and this was the only case I've ever found with elevated IgG4 in the bone marrow, which was kind of cool. I'm sure they're more prevalent. I just don't think we work them up very often, because if there's just a few plasma cells, we tend to say, no, it's not myeloma and move on. So this was an important lesson for me. He later developed sialaminitis and PBC. So it was pretty clear that this was IgG4-related disease. At the time, we didn't have the criteria, but I think I wrote really long comment that amounted to, of course, this is IgG4-related disease. In the lymph node, the bone marrow was a different case, and just hoped that they did the more work. And they eventually did get rituximab and responded. Any questions on that case? Thoughts? I really appreciate people putting stuff in the chat. I'm glad that I can see both. Yeah, it's a great question. Nothing. This was a high degree of suspicion. So this person actually, the node was actually in a patient with generalized lymphadenopathy that had already been worked up for almost everything. The only things they hadn't been adequately worked up for were the less common at the time rheumatologic things. I will say yes, when I see a lot of plasma cells in the germinal center, I do at least work it up. But as you mentioned, it's really non-specific. I think that's one of them. So the 2019 criteria did look extensively at lymph nodes and fundamentally found that it was neither sensitive nor specific. And so they sort of threw it out as an inclusion criterion because it was meaningless. Thank God they didn't put in a related exclusion criteria. So you can at least raise it. But yeah, when these come to me, they've usually already been worked up by HemPath. And then a clinician will reach out and say they have something. So I tend to throw the book at those, which my book is actually shorter than your book. It's only about 10 stains. So I think it's worthwhile, especially on a second opinion or consult. But yeah, plasma cells in the wrong place is definitely a clue. I would say any abnormal lymph node morphology that isn't neoplastic warrants a workup for things like multicentric IgG4, histiocytoses, which can be subtle, et cetera. That said, more often than not, probably most of those are infection, as you all know. But yeah, I think it's the high degree of clinical suspicion is the best clue. Clinicians have done a very good job of learning about this disease, mostly because the literature became saturated with an overdiagnosis for a period of time. But we're at 15 years-ish of this being a well-defined entity outside pancreas. So I think we're in a good place now for people to sort of say, hey, is it this? Most times the answer is no, but it's a whopping 2 stains to say no.
There's an interesting question from Alex. When you see plasma cells in the germinal center, do you always suspect autoimmune disease? I thought IgG4 positive plasma cells and follicles is less specific than interfollicular IgG4 positive plasma cells.
That's certainly what some of the papers say. I don't know that we've looked. The reality is I think too many of these cases are signed out. I'm not saying at your centers, I'm saying worldwide, as it's not lymphoma. And that even when an IgG4 is done, it's an increased IgG4 fraction, ratio, count, whatever, but you have nothing else to hang your hat on. So it's tricky. I will say that if it comes to me and there are plasma cells visible, I do the stain. Interpretation is always tricky, but I find having the information is better than not having it in those cases.
Great case.
Okay. Case 2 is also a 53-year-old male. Anyone feel like they're studying for Royal College? With mesenteric lymphadenopathy. This was the finding in a lymph node biopsy. On the edge of it, there was lymph node. Yeah, this one's pretty compelling for histiocytosis. That's the one 63 and the factor 13A. The CD1A was negative. The S100 was patchy. So this was a pretty compelling Erdheim-Chester case, which even histologically you would probably favor Erdheim-Chester. I'm glad you asked in advance. The BRAF V600E was dead negative, as was the panel sequencing. I didn't change my diagnosis. I was pretty comfortable on this one. The images are from pathology outlines. I had an extremely similar case. I didn't have digital slides available and I didn't want to go hunting for them. So I stole this from Path Outlines, but it was an almost identical story to this. And I still called it. I mean, that's what I thought it was. When they went digging deeper, oh yeah, by the way, they had long bone findings and perinephric fat stranding. So, it was pretty compelling. Didn't really fit with anything else. Unfortunately, really bad news for the patient. Most histiocytoses are progressive, and even the new kinase inhibitors are hit or miss. So that was kind of unfortunate. I didn't get any follow-up on the case, but no one was optimistic. Okay, I have already ruined 1 hour of your life. Please feel free to reach out to me. I'm going to stick around in case there is any thoughts that come up during the other presentations. I'll be around at the end to chat. Thank you so much for the opportunity.
Thank you so much, Michael, for giving such an amazing talk. Everyone learned a lot from you, and you'll get the evaluation link, which will be in the chat box. But the event is not over yet. We'll be having 2 presenters, volunteer presenters. The first one would Dr. Taban Ghafaripur. She's the hematopathologist at McMaster University at Hamilton Health Sciences. So she's here. She will be presenting one related case to us.
So the name of the topic I'm talking about is pancytopenia, blast, and new leukemia, a Christmas miracle after all. My name is Taban Ghafaripur. I'm assistant professor of pathology at McMaster University, Hamilton Regional Laboratory Medicine Program. So it was a 16-year-old boy who presents with 1 week of abdominal pain, emesis, headache, and tactile fever, with history of 20-pound weight loss within the last year, and from the referring institution found to have profound pancytopenia and rare circulating blast, suspicious for acute leukemia. CBC showed a severe pancytopenia, as you can see, with macrocytosis, and RDW was also high. Reticulocytes, retic, they were not increased. However, retic hemoglobin E was a little bit increased in addition to a little bit increase in immature retic fraction. Apart from unconjugated bilirubin, which was a little bit increased and markedly increased lactate dehydrogenase, there was no significant other abnormality. Iron, ferritin, C-reactive protein, calcium, and other electrolytes, PT, PTT, INR, they were all negative, normal. On peripheral blood smear review, as you can see, we had profound pancytopenia. The RBCs were macrocytic with some polychromatic forms, and we also noticed some nucleated RBCs. Some of them showed some dysplastic features. Instead of pure circulating blast, we had this leukohydroblastic picture with a subset of neutrophils showing hypersegmentation of the nucleus. So the decision was still made to do a bone marrow biopsy because still the suspicion for leukemia was high. As you can see, we have the cellular marrow with erythroid predominance, and there's a left shift in the erythroid precursors. with a lot of pro-normocytes, in addition to these plastic features, like nucleus to cytoplasmic asynchrony and some megaloblastic changes. The background, as you can see, a lot of blast. In the background, the myeloid lineage was not overtly dysplastic. This is another erythroid precursor showing megaloblastic changes with very nice sieve-like nuclear chromatin. Megakaryocytes were very few. However, the ones that we found were mostly normal morphology, no dysplasia. So on the counts, there was no increase in myeloid blasts. Erythroid cells comprised 50% of cellularity, and 20% were pro-erythroblasts with MU ratio decreased. This is bone marrow biopsy. As you can see, hypercellular even for 16-year-old, with increase in myeloid and erythroid lineage, erythroid predominant, and the erythroid precursors were left shifted in the background. We had some normal looking megakaryocytes. ECAT-Heron showed that this erythroid cells were indeed increased and left shifted. There were no increase in CD34 positive blast. Flow cytometry showed about 6% myeloid blast, no abnormal B or T cell population, no increase in plasma cell or monocytes. And by flow cytometry, we also detected this expanded population of erythroid precursors, which were 40% of nucleated cells. What do you think the diagnosis is here? What do you think? So we have like 50%, 50 people, no? Yeah, okay. So 60% of people said, 63% said acute erythroid leukemia, which basically shows that you didn't listen to me at all, because my topic was pancytopenia blast and no leukemia, a Christmas miracle after all. But that's fine. MDS with increased blast, well, that is definitely the differential. However, I would say people who chose bone marrow suppression due to viral infection and maybe other causes are probably more correct. All right, so what we should think of here, I think, which was the case, was vitamin B12 and folate levels, which I communicated to the clinician to basically measure. I can briefly go over why it's not acute erythroid leukemia, because it is very, very rare entity, and most of the patients are old patients. We need 80% increase in erythroid precursors with 30% blast. And these have TP53 mutation, but this is almost unheard of in pediatric population. MDS with with blast and the dysplastic features mostly in erythroid precursors is definitely a differential. However, I think this nutritional deficiency and viral infection should also be in the back of our minds. So vitamin B12, as you can see, was decreased, same as methylmalonic acid levels, which were then found out to be released. Folate and zinc were normal. So our diagnosis was hypercellular marrow for age with markedly increased left-shifted and megaloblastic erythropoiesis, decrease in mildly increased myelopoiesis with no increase in blasts or dysplasia, markedly decreased megakaryopoiesis with no overt dysplasia. And then we asked for karyotyping and NGS molecular, and we mentioned that pernicious anemia should be considered, and investigation for potential viral infections also advised if relevant. So parvovirus B19 being one of the causes of aplastic pure erythroid anemia, which stops maturation for erythroid cells and sometimes can cause other cytopenias, was basically the main concern. I mean, after nutritional deficiency, obviously. EBV was consistent with prior infection. Other CMV, VZV, and HSV serology was also negative. NGS and karyotype later showed that this was all negative. So then the investigation was made to find out about the underlying autoimmune disorder. As you can see, parietal cell antibody was negative. However, intrinsic factor antibody was positive. So as you can see here, the patient literally come to us on Christmas Eve. These are the CBC, and this is the timeline. And after about 50 to 60 days, everything became normal after injection of B12. Later, he had a biopsy of GI tract, and in the gastric body, atrophic gastritis was identified consistent with autoimmune gastritis. A little bit about megaloblastic anemia is decreased synthesis of intracellular methylene tetrahydrofolate, essential for maintaining DNA synthesis, and the most common causes are folate and vitamin B12 deficiency. Other causes can be direct interference by DNA synthesis by medication, toxins, MDS, and HIV. Sometimes neurologic symptoms occur before hematologic ones, and this can lead to misdiagnosis. So the key intersection so this picture is showing methionine cycle, folate cycle, and DNA synthesis. The key intersection of B12 and folate occurs at the methionine synthesis reaction, in which one carbamethylene group of methyl tetrahydrofolate is transferred to homocysteine to form methionine. The cofactor here is B12 in the form of methylcobalamin. The folate product tetrahydrofolate regains one carbon methyl group through the serine hydroxy methyltransferase reaction, and the resulting methylene tetrahydrofolate is essential for conversion of deoxyuridine to thymidine. And this is a very essential pathway for limiting DNA synthesis. When there is iron B12 deficiency, the folate mostly traps here. Sometimes with administration of folic acid, the hydrofolate is performed, and then through this pathway, it can temporarily, make things go. But at the end, B12 is very important for this pathway. Another substrate that's important is methionine here, which through making SAM, S-adenosylmethionine, provides methionine for multiple, multiple pathways. It's a universal methyl donor in numerous methyltransferase reaction, which at the end changes to homocysteine, and this is an important pathway in our body. So normal pathway of vitamin B12 absorption, when we digest food, it's going to be attached to haptocorrin, which comes from salivary glands, and also in the stomach we have these gastric parietal cells that produce intrinsic factor. In addition to biliary B12, which is also attached to haptocorrin, in the upper small intestine, with the help of pancreatic trypsin, digestion happens, and then B12 is going to bind to intrinsic factor. Together in the lower small intestine, terminal ileum, they're going to attach to this Coblin amylase complex, and then they're going to enter to the ileal mucosal cells attached to multidrug resistant protein 1, and then this helps B12 to come to the blood plasma, where they also attach to transcobalamin. With the help of transcobalamin, B12 can be absorbed by different cell types in the body, and there it serves as methylcobalamin and adenosylcobalamin, both in cytosol and mitochondria. So, anywhere in the body which we have defects in this, organs, we're gonna have this problem, megaloblastic anemia. So laboratory diagnosis, earliest hematologic manifestation is increased MCV, pancytopenia, anisopoikilocytosis, neutrophils with hypersegmented nuclei, mild to moderate thrombocytopenia, leukoerythroblastosis, Howell-Jolly bodies, which are basically DNA remnants and remnants of the mitotic spindle or abnormal nuclear membrane material, respectively. Bone marrow shows trilineage hyperplasia with erythroid predominance most of the time, with megaloblastic dysplasia in erythroid lineage. And rare cases may show profound left-shifted maturation and dyspoietic changes mimicking acute leukemia, which was our case, basically. Giant metal, myelocyte, and band forms can be seen. One thing that can differentiate that from MDS is the presence of normal-looking megas as opposed to dysplastic hypo and monolobated megakaryocytes. Again, so this defective DNA synthesis results in unbalanced cell growth, and this is more cell growth of immature nuclei with mature cytoplasm. This is mostly seen in rapidly proliferating cells, including luminal epithelial mucosal cells of GI tract, cervix, vagina, and uterus. Also, erythropoiesis increased and ineffective. As I mentioned, anywhere in the GI tract with basically gastritis, gastrectomy in the stomach, celiac disease, any problem in the distal ileal mucosa can cause megaloblastic anemia. Poor diet with people who practice extreme veganism can be seen, and also pernicious anemia, which is basically a failure of gastric mucosa to secrete intrinsic factor, which is necessary for absorption of cobalamin. This usually takes 3 to 4 years for absorption before deficiency develops. The laboratory analysis, we have transferrin saturation, which is increased due to ineffective use of iron. Sometimes concomitant iron deficiency can result in normal MCV, masking the megaloblastic signs. Serum iron will be increased, absolute reticulocyte lowered, bilirubin, mostly unconjugated, increase with a decrease in haptoglobin and increase in LDH due to some hemolysis. And serum B12 and folate levels should be correlated with symptoms for thinking about such diagnosis. So additional analysis is to measure methylmalonic acid and homocysteine levels. If both are normal, there is no deficiency in B12 or folate. If both are elevated, there is definitely deficiency in B12, but that does not eliminate folate deficiency. As you can see here, we have methyl tetrahydrofolate that might be decreased if MMA is normal and homocysteine is elevated, no deficiency of vitamin 12, consistent with folate deficiency. So serum folate is highly sensitive to folate intake and can correct after healthy meal, even in the presence of folate deficiency. Therefore, red cell folate is more specific for true deficiency, and red cell folate may be low in vitamin B12 deficiency, even if adequate folate is present. Thus, vitamin B12 deficiency must be ruled out before folate deficiency is diagnosed. My classic clinical findings, some neurologic features can be seen in vitamin B12 deficiency, such as patchy demyelination and peripheral neuropathy, as well as paresthesis and decreased proprioception. And then you have this basically anemia-related symptoms. In folate deficiency, we have first anemia related symptoms, and then we might have increased skin pigmentation, and then GI symptoms. Neural tube defects can be seen in fetus if there is folate deficiency during pregnancy. Differential diagnosis, so MDS with erythroid lineage predominance, dysplasia is definitely one of the diagnoses. A pure erythroid leukemia, again, it's mostly very, very rare and mostly seen in older people. TTP is also a diagnosis, differential diagnosis, because it can exhibit neurologic symptoms with hemolytic anemia, thrombocytopenia, schistocytes, and elevated LDH that we may think that's probably due to TTP. Collagen vascular disease like SLE, rheumatoid arthritis, are also considered in the differential because they can cause cytopenia and the secondary megaloblastic anemia. So that's also some consideration, and also medication and toxins. Treatment is replacement, obviously, orally or intramuscularly with intramuscular vehicle for people who have absorption problems. So we expect the erythroid precursor to lose megaloblastic features within 2 to 3 days. In ground-stick lineage, these changes persist a little bit longer. Hypersegmented neutrophils resolve within 1 week. WBC normalizes very quickly. And marked reticulocytosis peak within 4 to 10 days. And then normal CBC parameters within 1 to 2 months, as you could see in our case. Prognosis is excellent if treated. Some neurologic symptoms may be irreversible if diagnosis is delayed. And obviously, autoimmune disorders in pernicious anemia may be linked to other adverse manifestations. That's it. I don't know if you have any questions.
That's great. Thank you so much, Taban, for
No worries.
presenting such an excellent case and an excellent overview. We have a few comments and then follow-up
I'm
questions.
sorry.
I think when you were putting the poll, Larissa got the answer B12 level that time. Then we have a comment from Vinod. What about peripheral blood MCV levels? So I mean, after treatment, it should be, normalizes in 1 to 2 months. Sarah has a question. Did the patient have circulating blast in your case?
So it was mostly leukoerythroblastic picture. So yes, very rare, but as part of the leukoerythroblastic picture.
Perfect. Thank you so much. Thanks
No
again,
worries.
Taban.
No worries. No worries.
Okay, we have another presenter, Dr. Alexandra Plaga from Ottawa. She's the hematopathologist. Alex, please take it away. Thank you so much for presenting the case.
This case was of a 62-year-old male who presented with lymphadenopathy and was really ill. And the lymph node, I would have shown a low power of it if my camera was cooperating. But essentially there was follicular hyperplasia, but in the paracortical areas were large atypical multinucleated cells, some with prominent nucleoli, some with Hodgkin-like morphology. So those were notably present, but also in the lymph node sinuses, you could also see atypical cells collecting. And so a CD30 stain was done, and it was positive in the large atypical cells, which made me feel pretty good about entertaining a diagnosis of classic Hodgkin lymphoma. CD15 was done, and it showed sort of this unusual dot-like positivity, Golgi-like staining in the atypical cells, which was also working towards a Hodgkin lymphoma, even in the sinus areas. And then PAX5 was odd. It was completely negative in the vast majority of cells, though there was a focal area that did show some dim PAX5 positivity. And so at this point, started to think about differentials for classic Hodgkin lymphoma, and particularly given the really sinus distribution that was highlighted by CD30, anaplastic large cell lymphoma came to mind. And so with that differential, you would usually anaplastic large cell lymphoma should be PAX5 and CD15 negative, but rarely it can be positive. And so looking at the CD45 in the sinus areas, it was a bit difficult to tell. It looked positive in some of the cells. But then in the areas that were PAX5 negative, I could convince myself the 45 was negative. Next followed a CD43 stain, and it was strongly positive. So CD43 should be negative in classic Hodgkin lymphoma, and it is often positive in anaplastic large cell lymphoma. So that opened up the door for more stains to investigate further. CD4 was negative, but EMA was positive in the cells that were in the sinuses. And then CD8, a T cell marker, was also strongly positive in those cells. And then finally, I did some reading and read that P63 can be expressed in anaplastic large cell lymphoma and is typically negative in classic Hodgkin lymphoma. And so this was my first time using P63 for this differential, and it actually came back positive in the cells. And so therefore, this case was signed out as and ALK protein was performed and it was negative. Had ALK protein been positive, it wouldn't have been much of a struggle, but it was negative. And so this case was signed out as an anaplastic large cell lymphoma, ALK negative, which I thought we could just quickly review. It is a mimicker of classic Hodgkin lymphoma, and I had always read that ALCL can have some PAX5 positivity and can sometimes be CD15 positive. And I had seen one case that was CD15 positive in the past, but I had never seen one that was PAX5 positive. So this proved to me that it's true what the textbooks say, anything is possible. And so ALCL, ALK negative, it's a mature T cell lymphoma with a uniform strong expression of CD30. By definition, ALK is negative. Less than 50% of the cases express T cell markers, but CD43 is commonly expressed positive, and it can be the only positive marker sometimes. And CD8 expression is rare, but luckily this case actually had it. And fewer than 20% of cases have T cell receptors, express T cell receptors by immunohistochemistry. And there is, and so these can be T cell lineage null. And MUM1 is usually positive, but that doesn't help us with the differential for Hodgkin. And EMA is rarely positive versus Hodgkin lymphoma is almost never positive. And if it is positive, it should be weak and patchy. And so the essential criteria is that ideally you have lymph node or external tissue with large pleomorphic cells with low beta nuclei and distinct nucleoli, as our case. The hallmark cells weren't in your face, but you could definitely find cells that were, you could talk yourself into a hallmark cell. But for me, on initial looking at it, I thought of Hodgkin first. I was able to see more cells that resembled Reed-Sternberg cells and hallmark cells. You need uniform, strong expression of CD30, and EBV has to be negative. And desirable, it's nice if you have T cell markers and cytotoxic or T cell cytotoxic markers and or clonal TR gene rearrangement. And then regarding the P63 expression, so there is a study, this is a study I pulled up when I was reading about how to differentiate anaplastic large cell from classic Hodgkin lymphoma. And so in this study, they looked at 58 Hodgkin lymphoma cases and none of them showed P63 expression, while about 40% of anaplastic large cell lymphomas were positive. Another study looked at the correlation of P63 immunohistochemistry with P63 translocation that is seen in anaplastic large cell lymphoma ALK negative, and they found that the immunohistochemistry did not, often the immunohistochemistry was positive because of TP63 amplification rather than gene rearrangement. So it's not a perfect correlate, and just because your P63 is positive, it doesn't mean that you have the translocation. And so, yeah, overall, just to remind everyone, especially those that don't often sign out lymphomas, especially if you have a biopsy from an older patient over 50 with disease in more than one site, you need to think about mimickers of Hodgkin lymphoma at that case. And you should have a more extended panel, include additional B cell markers. I always include a CD20, CD79, in addition to the PAX5. I like to do 43 more than 45 because I find it easier to interpret, and it can be very helpful. And yeah, and particularly EBV positive cases that are lymphocyte rich or with mixed cellularity in older patients with advanced stage disease should really prompt you to consider mimickers. The main ones being angioimmunoblastic T-cell lymphoma can have really good Hodgkin cell mimickers, and peripheral T-cell lymphoma, NOS, can also have really good Hodgkin mimickers. And then anaplastic large cell lymphoma. And also I recently had a case as well of a primary cutaneous CD30 positive lymphoproliferative disorder in the skin that was then involving an inguinal lymph node. And that has also been described. So yeah, that was just my short review. Thank you very much.
Great. Thank you for sharing such an amazing case, Alex. We have a comment and actually a question. Actually, Michael and we have the similar question. Any NGS did you do on your case, or did you do any cytogenetics or molecular studies in addition to the T-cell clonality? I mean, in addition to the clonality testing.
Yeah, so we tried clonality, but it failed, and we didn't repeat it. We have trouble with our formalin fixed tissue doing it. And then next-gen sequencing, we don't have funding for it, so we have not been doing any next-gen sequencing on any of our lymph nodes.
And a question from Taban, which T-cell markers were positive in this case?
CD43 and CD8.
And from Sarah, very tricky case. She had a recent case of ALK negative anaplastic large cell lymphoma that was PAX5 positive, CD30 positive, but CD43 negative. Again, I would like to thank everyone for attending today's talk. And thank you, Dr. Michael Seidman, for giving an amazing overview. Thank you, Taban, for presenting an interesting case. And also thank you, Alexandra, for presenting the case as well. Thank you, everyone, and have a great day. Bye-bye.